Hello, everyone. Hi, welcome, sons. We're excited. You've made it. Please let us know you're here. Type it in the chat that you're here. We want to know who's with us today. Well, welcome. And for the best experience today, we always remember our rules of make sure you have a computer that's connected and has plenty of battery power. The other thing is check your chat and address your question, or make sure that the chat is addressed to everyone. When you have it to the panelists, everybody doesn't know what you're asking. So just check that as you enter and put things in your chat. Closed captions are available, and this session, as is all trainings, are recorded. So no worries if you missed part of it. Absolutely, you can catch up with our trainings and we'll give you that link, okay? Well, welcome Claire, welcome Martha, hello. Hi Scott and Alicia, welcome. Glenna is back, Louisiana is in the house. I'm always excited to see you, Glenna, joining our trainings. Hi Jimmy, Ben from Sacramento County Juvenile, welcome. Jamie from New Mexico, well, welcome. Wow, we're just global today. Good morning from Joshua. Dale from Temecula, hello. Hi, Clarissa over at San Gregorio. Hello from St. Jude. Welcome. Oh, we have Leilani from Spokane, Washington. Wow, this is wonderful, you guys. I could just keep reading forever and then I would stop our program. So my name is Sherry Cisneros. I am the Sun Program Director here for California Bridge, for those who don't know me. This is our Sun Training 101 session, newest trends in harm reduction. You guys keep asking for harm reduction and we deliver. So we have a great lineup today. So very excited to share this with you. Our objectives today, well, just we do not have any outside partners. We share our information. Our agenda today is update on harm reduction, and then we have harm reduction tips from our sons, actually our son mentors. So we're going to get started. Today, these are the objectives, and I really just wanted to let you know, if you need more about harm reduction, it is on our Sun landing page, the links. So always feel free to reach out to us. We can, if you don't have those links to harm reduction and their free 3-course bundle, we can always add it to Slack. But it's a great start. If you're just joined us and this is your first time, please let us know. It's always a great resource to get that 3 free bundle from harm reduction. Most of you guys are it in your hospitals or your facilities. You're the only one doing this stuff. So again, if you need more information, please reach out to us. And actually, we put it in the chat as well. Thank you, Chaya. So I want to get started because we have our awesome speaker, Savannah O'Neill. She comes from our partner, National Harm Reduction Coalition, and she is the Assistant Director for Capacity Building. And I am going to hand it off to Savannah. Welcome. We're excited to have you here. I don't think you've been with our Sun Training 101, so we're excited to have you and what you're sharing today. It's really interesting, guys. You got just reading the slides, I was like mesmerized. So I'm going to leave it to you, Savannah.
Yeah, thanks so much for having me. I'm going to go ahead and share my slides. I'm really excited to be here today. I worked a lot with the people who are now Sun mentors, but have not gotten to see you all as much. So today, let me get to the top of my slides. There we go. Can you all see that?
Yes.
Perfect. So yeah, as I was introduced, my name is Savannah O'Neill. I'm the Associate Director of Capacity Building at the National Harm Reduction Coalition. I know you all have had other trainings from Charles Hawthorne on our team and other people before that. And I'm really excited to be here. I work basically supporting capacity building work for the whole state of California, working with the California Bridge Project, working on people who want to start harm reduction programs and giving them support, and supporting our 60 syringe service programs. And I come from a background in direct service. I've worked, so that's sort of how I'll be speaking today as well. I am a social worker by training, and I've worked in a methadone clinic and HIV testing. I've worked in clinics that do buprenorphine. So that's where I'm coming from, and now get to do this work. So for those of you who haven't had trainings from us as much, just a brief reminder of who we are. The National Harm Reduction Coalition creates spaces for dialogue and action that help heal the harms caused by racialized drug policy. So we are 25 years old, and we've done this work over those decades in a few buckets. We do policy and advocacy work at the national, state, and local level. We do regional and national conferences. We host the largest harm reduction conference in the world. We do a ton of trainings and technical assistance, so things like today, helping people learn how to do low barrier naloxone access, start a syringe service program, engage with people who use drugs without stigma. And that's a really big part of my work. We do a lot of overdose prevention. We run the DOPE project, which is the largest city-based low barrier naloxone distribution project in the country. And then we publish a bunch of resources and publications, which are available on our website. So today, I'm kind of focusing in. I know you all have had things on Harm Reduction 101. If you haven't and you happen to be new today, we do have 3 free modules on our website that you can access that go over foundations of harm reduction and how to engage with people who use drugs. But today I'm really going to focus on some recent data that we have through a project called Syringe and what we've learned about what's going on for people who use drugs in California and how we're making meaning of this data, and then specifically some of the trends we see around smoking drugs and supporting stimulant users. So what is a PIT survey? I did not know what a PIT survey was a year ago, and this is what I'm going to be talking about today. So really a PIT is a point in time survey. So it is something that lots of people deploy to get a snapshot of what's going on. So you could do it with a small group of people and just say, we're going to ask 15 people during this 1 week what's going on for them. Or we're going to ask 100 people over this month these few questions, rather than asking every patient every time they come in a question and getting consistent data. It's also like how they will do a homeless count, right? So if you live in a city with a lot of people living outside, they'll do a point in time count of everyone who's sleeping outside on any given night to kind of get a snapshot of that data. So we run a project at National Harm Reduction Coalition called the California Harm Reduction Initiative. And this funds 37 syringe service programs across 21 counties beginning in August 2020 to expand the range, reach, and quality of harm reduction services in California. This was allocated in the Budget Act of 2019, and it's funded by the California Department of Public Health Office of AIDS. So there are 60 programs that we support, but we fund 37. We fund their staffing and really their ability to expand their work. And one of the goals of Syringe is to expand access to medication for opioid use disorder. So it's almost like funding a son at a syringe service program. So it could be like the counter to a son in a hospital, someone who is at a program to help someone ask questions about buprenorphine, to ask questions about treatment and guide them into treatment. So it's actually a really good pair if you have a syringe service program in your region to ask sort of what they're doing around treatment access and have that relationship with the person within a program. So we administer the funds, and we're using PIT surveys, or point in time, as a core part of evaluating these programs. And we're doing that to specifically measure how these programs are including people who use drugs more meaningfully in planning, executing, and evaluating services. So not just asking programs like, hey, what were your successes, but actually having them ask their participants, what do you need, what's working well for you? So we're doing this 2 to 3 times a year. So I'm going to present today on the data from February 2021. We actually just completed one in October. But for February, we had 491 people who use drugs, who utilize syringe service programs, take the survey. It was over 3 weeks in February, and we sort of change our questions every time. So when this data from the one we just completed comes out, it will illuminate even more about stimulant use and smoking, which we'll share with you all when we get that. And we're able to make this cute infographic that really highlights the data that we want to go over. So we asked people a bunch of questions, and then we compiled, what did we learn? You know, it is hard to get real-time data, especially about marginalized people's experience. So this is really rare data to have 500 people who utilize services statewide tell us what's going on for them. Who are they? What kind of drugs are they using? What's going on with their access to treatment? So I'm going to go over some of these data points and then chat with y'all about like if that reflects your experience of people who utilize your services. So as I go through some of that data in more depth, I think I would ask you to reflect on what are your initial reactions to these findings? Was there anything that surprised you or was interesting? And given these findings, are there any immediate changes you can make to better support people accessing the services that they need in the hospital? And since these are syringe service participants, they might be different than people who are seeking care in the ED. So do you see similarities or differences between what's going on for people seeking ED-based services? Oh, I was trying to move my face. So the first is just demographic data, right? So this is just who took the survey. You can see the median age was 41, over 60% male, and over, majority straight. You can see the variance in gender and sexual orientation and race. Also majority white, with different races making up the other percentages. And I think something that we wanted to really pull out of this is that of the people we interviewed, 75% identified as unstably housed. So the majority of people were struggling with some kind of housing instability. And that was higher for people of color. So the highest rates were among people of color were unhoused. And so we see that as people who are utilizing services at syringe service programs. Then also sort of looking at drug use, right? This is also great because drug markets, drug supply, drug use changes and is different. So having real time data around this is really helpful. And I think this illuminates something that I knew, but it's helpful to see, which is that the number one drug in the state is methamphetamine, with 84% of people having used a stimulant in the last 6 months. So that could be people who use stimulants and opioids, right? Because 75% of people had used an opioid in the past 6 months, but stimulants being the number one drug that people are using. And that smoking was the most common route of administration, with 87% of people smoking drugs, followed by 77% of people injecting, 43% snorting, and also that. So basically, we're seeing still high rates of heroin use, high rates of fentanyl use, but methamphetamine being the most commonly used drug. So this, we asked a lot about MOUD. So again, at syringe services, people using different drugs. And this was sort of targeted to what folks would want to see at a syringe service program, but I actually think it's interesting for you all to think about. So 29% of people said they wanted actual MOUD services at syringe service programs. And that was because they wanted people who treated them non-judgmentally. So that being a core piece, right, for takeaways for you all is that if you can create an environment where people are not judged, that is where they want to seek services. And we know that syringe service programs in particular have that deep community level trust. How do we build that in other kinds of environments? And then looking at barriers, which I'll go a little more into, but transportation was the top barrier around MOUD access. So is that something you're seeing for people? Is that one of the reasons they have fallen out of treatment or not gotten treatment? Is the ED more accessible than other places? Sort of what comes up around transportation as a barrier. And then we asked both about methadone and buprenorphine, and I'm going to go more into some of these other barriers that people said. And I think something that's interesting is that, most people knew what buprenorphine was. So vast majority of people knew what it was, but 10% reported that they didn't know what it was. So there's still an opportunity for syringe service programs to do this education, and there's an opportunity for you all to work with syringe service programs, to partner with them to provide education for their participants and staff, because there's still a gap in people really understanding what resources are out there and what they really are. So just to go in a little bit more to some of the barriers, specifically around buprenorphine, I pulled these out, um, was that people didn't like it, which that's real, right? They didn't feel like it helped. They didn't like how it felt in their body, or they had a bad reaction. Another huge one was just experiencing clinical and bureaucratic barriers. So issues with insurance, issues with pharmacy access, ID requirements, other high barrier clinic requirements. So knowing that we want to make buprenorphine as accessible for people who want it as possible, what are the ways that you all are already supporting people navigating these bureaucratic barriers? And what else can we be doing to do that? And again, transportation, accessibility, distance. And I'm curious, if people have in the chat, you can share also at the end, like, are there things you're doing to mitigate some of these barriers for people? These are just quotes, just to think and illuminate those experiences, which I'm sure you all have heard. The first one, it was harder to use than methadone because you had to detox and get sick. It induces withdrawal. And some of these things, right, we know people have a bad experience with care, and that's not always true, but people hold on to that experience. So how do we build trust with people, talk through how you can do this and not put someone in withdrawal? I wasn't able to fulfill the obligations to go to meetings, and my motivation went down. I was going to classes, I got kicked out, they were ruthless. So again, these kind of like high barrier, high regulation issues that I think California Bridge Project has really tried to shift away from, and is really great in responding to some of these reasons people are not enjoying their experience with bupe. Great, I see people are like able to offer transportation for your patients, which is amazing. You're not doing punitive drug screenings, and you're available same day, anytime, and they can refill group therapy as well as in the clinic. That's really awesome, giving people multiple options for where they can get prescriptions. Yeah, I love all these comments. I met a man this week who was reluctant to start Suboxone because he heard getting off of it was worse than heroin. Any response for his concern? I would love if people want to put that in the chat as well, if you have a response to Glenna. That's something I've heard a lot in my work. And I think we have to be real with people about what those different experiences are, right? That if you do decide to go off bupe, there is, withdrawal, but how do we mitigate that? How do we support people? Heroin is an unregulated drug supply, and buprenorphine is a stable drug supply that you can, a medication that you can taper off in a much more controlled way. And I would talk to someone about, like, what are you scared of? What are the things that come up for you? And talk about how tapering off does work. We offer discharge documents, free ID vouchers, help with transportation, bus cards, gas cards. Yeah, ID requirements are huge, partnering with the county to get ID vouchers. It just didn't work for me. I heard other people say that Suboxone just doesn't work for older people. Again, these are things people say, right? And how do we kind of have conversations with people, both not to convince them to use something they don't want to, but to investigate what's under that for them, what's the actual need or concern. So these are suggestions for syringe service programs that participants had. So 233 people decided to say, hey, this is our recommendation for you. 34% said, y'all are doing awesome. You make us feel comfortable. You always offer access. And I really actually wanted to highlight this for you, that 29% of people said that syringe service programs in the community could improve treatment information and counseling, so that they really want someone to offer information about treatment at SSPs, talking to more people and teaching about side effects. So I think that gets at that concern of someone saying it's worse to get off than heroin. So people want someone who can talk through that with them, talk about the side effects. How do you address those? Can distribute literature, can have conversations. I think to the comment in the chat, a lot of people who are going to 12-step programs are told they're not clean if they use Suboxone. So people want someone to be able to have that conversation with. That was something I experienced a lot when I worked in a methadone clinic. I worked in a clinic for 5 years, and people were very concerned about that they couldn't access recovery community if they were on a medication. So how do we really talk to people about that? and not only maybe medical side effects, but social side effects and the stigma that still exists around, evidence-based medication. So I don't know if people want to share how they respond to those concerns in the chat. Again, we have transportation issues. It's awesome to see that you all are doing so much to share information about how you do free ID vouchers and how we navigate bureaucratic systems for other people. Then we have the last one is, that people were like access to resources, ID assistance, SSI benefits, better detox. So I see this as really an opportunity for sons in your hospital to partner with syringe service programs around these topics. So then in the last few minutes, what are your takeaways from this data? So my questions to you all would be, what do you offer to stimulant users? If most people are smoking drugs in the state, what harm reduction tools can we offer to people who smoke drugs? How can California bridge sites reduce transportation barriers? And so those are my questions that I would ask you to ponder. What other ones do you have, or what else do you notice from the data? It sounds like that third point of how you can reduce transportation barriers, you're already deeply thinking about and addressing. What else comes up for you?
Well, while we wait for people to put in the chat, I do want to ask you a question, Savannah. Something I get asked a lot of times is, I don't have a harm reduction in my county. What advice can you offer, or a syringe exchange program in my county? What can you offer them or guide them as a tool for them?
Yeah, that's a great question. So it's true, there are many more hospitals than there are syringe service programs. We still see huge lack of syringe service programs statewide. So if you don't have one in your community, there are still things you can do. You can integrate harm reduction supplies into your emergency department, which many programs have done, right? Naloxone access, low barrier naloxone access, syringes. The state is actually working with a number of hospitals on actually becoming certified as their own syringe service program, having access to supplies. I see Rebecca put pipes and hammers, giving out other tools for people. We're about to do a study that looks at, does giving out pipes reduce injection, right? Which has all kinds of health benefits. So if we're able to give people other routes of administration, how does that reduce infectious disease or other drug-related harms? And then I would say next, harm reduction does mail-based harm reduction services. So if you live in a rural area or an area that is not amenable to harm reduction, that's a resource you can give people to get their own supplies directly mailed to their homes. And then the other really big thing I think is syringe service programs. The reason I've worked in them for so long is like, not because giving people needles is like so thrilling, it's kind of boring, right? But like, what is exciting is creating a space where people have no incentive to lie to you, and there's immense safety and a lack of stigma, and you can still create that and engage in harm reduction even without the tools and resources. And I'm going to read in the
Yeah, I was starting to read the chat, and I think this is a lot of a question that a lot of people are thinking about is fentanyl strips. How can we get them and provide them to our clients? Do you have any suggestions for our sons?
Yeah, so fentanyl test strips are available at syringe service programs. You can also give them out legally. You can order them through BTNX Harm Reduction and distribute them to clients. In 2018, the California Health and Safety Code essentially says it's legal to give out any of these supplies. So you have to have funding for them, but you can order them directly through BTNX that produces them. You can partner with a local syringe service program if you have them to distribute them.
Great. Those are
and
great.
I see some other people are, yeah, and feel free to reach out to me anytime if you have questions about this stuff. My email is o'neill@harmreduction.org, but we're happy to strategize with you about how to do those things. I love the conversation in the chat about how you all would address stigma within 12-step programs. That's a huge thing. My colleague who I often present with, that many of you have met, Jenna Haywood, has talked about it a lot in her own experience in 12-step and how to have a harm reduction approach while being involved in that program.
Yeah, definitely. And I do, thank you for sharing all your suggestions, Savannah, and your email, because I know for those who really want to speak to Savannah again, we're going to have a virtual fair coming up in a few weeks. I know we could stay here all day talking with you, Savannah. Like I said, we're thirsty for this wonderful information, and I really appreciate it. Is any parting words before we move on?
No, I mean, I think that's great. I'm available. This is like always evolving, right? And I'm incredibly impressed with the way that SUNS and the Bridge program have really led on harm reduction in a way it hasn't been centered in the hospitals. And because there's so many more hospitals than there are community-based syringe service programs, I think there's a huge opportunity for you all to engage in this work. I'm available. I'm going to put some stuff in the chat so you can reach out to me, and I'm going to let you hear from the Sun Mentors now. Thank you so much for having me.
Thank you so much, Savannah. You were awesome. I love the data, you guys. That was just, that's real raw from the field, right? This is not made up. This is people that are going in and using drugs, and they're giving their honest opinion. And again, that's our goal right here for California Bridge, to come into the hospital without stigma. I know there's a side conversation, a lot going on about 12-step sober programs and MAT. I want to remind you, our California Bridge model is that substance use is a chronic medical condition. It is an illness. So when I talk to people that say they're not sober, well, you would not call a patient that gets blood pressure medication, would you? It's the same type of medication, even though it's for high blood pressure. They are receiving a medicine for a medical condition, okay? Just like hypertension, just like diabetes. So really, a patient does not need to disclose. If they are getting treatment, they would not tell their 12-step program, I'm on insulin, I'm on hypertension medications. It's the same thing with Suboxone. It is your medical condition. And so I really, really want to make sure that you guys understand that, because that is one thing, I hope you leave today along with all of the wonderful information Savannah has expressed, is that we know substance use is a medical condition. It's a chronic illness, and it is just the same as diabetes. And it's up to us. Savannah, we offered out that 3-course bundle. You're the harm reduction specialist, and you know what, one at a time, right? We can't change the world, but just one at a time. Just focus on somebody, just one. We don't ask you to change the world. You got to do what you can do in your just like harm reduction, meet people where they're at. Same with your staff in the emergency room, meet them where they're at. So without taking up more time, I'm going to share my screen. Thanks again, Savannah. That was just awesome. I love the interaction of what's going on. So I'm sharing my screen, and we're going to go up to harm reduction tips from our Sun Mentors. Our first Sun Mentor is Angela Caldwell, and she's going to talk about interrupting stigma. Angela.
Hi, everybody. So glad to be here. I'm going to just give a little bit of information, some tips on standing up to stigma in your emergency department, things that I have used and continue to use. My first thing is be the example. So we need to walk around and be the people that are breaking this stigma, talking about addiction openly. It's out there everywhere. Don't make it taboo. Talk about it. It's okay. Using supportive language that is not stigmatizing. Words matter. We have that in our toolkit, different things that you can use, different words you can use to address these different disorders. Speak out, advocate for your patients. We need to be the ones that are standing up for them. They don't have people standing up for them that often. So we need to, if somebody's saying something, educate them. Teach our team how to say things that isn't going to offend our patients.
Hey, Angela, I'm going to pause you for a second. Your sound is coming in and out. Is there any way you can move closer to your microphone?
I'm so sorry. Is that a little bit better?
Yes, that sounds
okay.
better right now.
Okay, sorry. Should I go back to some of these things, or were you able to hear me? I'll just go back over it really quickly. Talking openly about addiction, using supportive language. Check out our toolkit that gives you words matter, gives you different options to use to address different types of drug use or ways to talk with our patients to make them feel more comfortable and cared about. Speaking out and advocating for your patients is a huge part in the emergency department, educating your team. Another thing that I think is big is sharing your story. If you have had a substance use disorder, share that with your team if you feel comfortable doing so, or maybe sharing a story of somebody close to you. Letting people know that we're human, that this substance use disorder, opiate use disorder is out there. It's not prejudice. It's our families, it's our friends, it's our coworkers. We have a nurse in our emergency department that has no problem letting our providers and other coworkers know that that she wouldn't be standing there today if recovery didn't work. She went through it herself, and there she is supporting our team and helping us. And that just makes such a huge difference when people understand that it could be you, it could be your sister, it could be your coworker or friend. Another thing that I do is I share my patient success stories with the team. Let them know that they are making a difference too. We did this, like we helped this patient, and look at what happened. They're doing well. They have a job. They're, 6 months into their recovery and doing amazing. They need to hear the positive stuff as well. And then praising your team is something that I do. We have a Facebook for our emergency department, and I will go on there and I will say, thank you, Sherry, so much for helping our patient. I love the way that you were with them. And, they told me how awesome it was. Their experience was great. And just praising in front of everybody so that everyone can see, oh, wow, it does make a difference and things like that. We need to be there for our patients. We need to educate our team. And the more you do it, the more that people will follow along and do it right along with you.
Great. Thank you so much for your tips. I love the stories. That's a great way because it kind of breaks the ice with everybody, wants to do better. So excellent tips, Angela. Next up is patient advocacy with some mentor Chaya Vang. Chaya, are you with us?
Yes, I'm here. Can you hear me?
Yes.
Okay. Hi, everyone. I will be discussing basic patient advocacy. What are the over some things I normally do? I would also like for you all to share your own tips in the chat box. There is no right or wrong answer, so please share away. Patient advocacy is basically being there to support the patient. There are many ways we can do as to practice this, and I will go over some direct and indirect advocacy. Direct advocacy is being present with the patient. We could provide low barriers to treatment, such as offering buprenorphine in the ED. I have found that patients appreciate it when we are checking in on them and we tell them what to expect, such as your medication has been ordered and we're just waiting for the nurse to give it to you. Or the doctor is going to come back to reevaluate you, don't leave. So what if patients don't meet criteria to get started in the ED? Our job is to speak up for the doctor and the patient and advocate for a home start buprenorphine prescriptions. Remember, we should always meet patients and doctors where they're at and believe what they're saying. Offer Narcan to everyone. Those that deny Narcan, I usually convince them that it can save a life, and it usually gets them to accept it and take the Narcan. And always remember to make that referral and provide resources, whether it is just for continuation of buprenorphine treatment or other STD services. There'll be one less things that patients have to worry about. And like I said earlier, reminding them that we're here for them is the number one thing we can do. Indirect advocacy is providing education, outreach activities. And how is this advocacy? Because we are bringing awareness and creating conversations about something that people don't talk about at all. Having posters and brochures posted in patient areas such as lobby, waiting rooms, and even the restrooms. educating the staff constantly by participating in in-service opportunities and committees in the hospital, hosting events such as National Overdose Day, or I remember another son suggested having booths set up in the cafeteria and just talking about your program. Definitely find out what you can and cannot do through management, obviously, but simply being present in the ED will help your program grow, because somebody will ask you what your position is, and it's the best time to talk about yourself and your services. Having these constant interactions with staff the staff will remember you, and when they see somebody struggling with STD, they will definitely remember to reach out to you. That's all my tips for now. Thank you so much, and up next will be Wendy.
Thank you so much, Chaya. Wendy, are you here?
Yes, I'm here. Hi, everyone. Good morning. I am going to be discussing the importance of medicated assisted treatment in the emergency room and having access to buprenorphine. So one of the things that it does is decrease the amount of shared drug paraphernalia. And then to piggyback off of that, if we're reducing the amount of shared drug paraphernalia, that reduces the chances of STDs, including HIV, hepatitis C, and also helps with reducing the chance of soft tissue infections. I have seen numerous times people having to have amputations done because of soft tissue infections, and it's very disheartening, and to counsel with those patients after their surgeries. Obviously, most of them are open to receiving MAT treatment after such an event, but if we could prevent it before that happens, it is extremely important. It also helps people with opioid use disorder, gain a sense of normalcy. You will quite often hear people who use drugs when they receive their first dose of buprenorphine and they have never used it, they usually will say they feel quote unquote normal. And they gain a sense of self. They gain a sense of being in reality. And we usually like to encourage patients within a couple weeks after their first induction to become a little productive, have them keep busy, and they usually are ready within a week to start doing something, and we just want them to stay busy until their next appointment, their follow-up appointment. And at the end, medicated assisted treatment saves lives. We're meeting the patients where they're at. If they do not meet criteria to receive MAT treatment when they come into the emergency room, we want to make sure that they know they could come in 24/7. If you have a naloxone distribution program at your site, we always want them to leave with naloxone, harm reduction information. I am blessed to have a harm reduction site in the Inland Empire where I live, and I have their phone number. I have information regarding what they can and cannot do, and when a patient is not ready or needs to come back another time for induction, I make sure that they leave with that information in case they need clean supplies.
Great.
And we're all saving lives together, guys.
Thank you so much, Wendy.
You're welcome.
Next up is Rebecca Bartley. She's going to talk to us about syringe exchange. Rebecca, are you here?
Hey everybody, thank you. So I'm going to flood the chat right now with some resources. If you could go to the next slide, please. the first resource, I encourage you guys to copy these links, open them up, copy them, and put them in an email to yourself or a Word document, because this is direct action you can take in regards to syringe exchange or services in 3 different ways. So the first one I'm going to give you is local action. And that means what we can do with our communities. So these 2 links are interactive maps that you can zoom in on your area of California and check which harm reduction services are near you. Like Wendy just said, her and I both are on opposite ends of San Bernardino County. And we only have the one syringe exchange service program called IEHR. And they do deliveries, they do mail orders. So it's just important to know what's around you and then collaborate together. Let them know, like, hey, I'm a new son. This is what I'm doing with my program. I wanted to give you my info so that if someone's looking for Matt, you can connect them with me. And ultimately, you're creating a stronger community by doing that. So check those 2 out for local action. One is the NASEN map, and the other is National Harm Reduction Coalition map. They're both links for California, so check those out. The next set of links I'm going to give you is for mail order resource action. So this is especially for sites and important to you if you don't have syringe exchange services near you. This is what Savannah was talking about earlier to Next Distro, and they are entirely mail-based, discrete mail order services where folks can order syringes, cookers, tourniquets, sterile water, Narcan. I encourage you, this is an amazing resource. You need to have this information and be giving it out to your participants. Like, hey, we don't have a Narcan distribution project here, but here's where you can get it. Look up Next Distro and encourage to help them with the process. You can, I like to take out my phone and, order with them, especially family members, like a mom calling you, hey, my son's on the street and I don't know what to do. He won't come in for services. I give that resource, Next Distro resource to family members as well. And the third one is direct local site action. So I love this because California Bridge is amazing, and they are providing us resources for how to get sterile, safer usage supplies into the hands of our participants who walk in the door to our sites. So this resource is for a safe injection harm reduction kit example. So the first link will be to a, thank you, Chai, I appreciate you putting that in the chat for me, will be the resource, like how a kit looks, right? And then the next one is going to be an actual order set that you can either copy or create a model of to get harm reduction, safe usage supplies into the hands of folks who walk into your hospital. So this is something that we can start, go to your champion and say, hey, I found out about this resource today. Go to them, get their buy-in, and then move from it there. Same thing, how we're doing our Narcan distribution projects. This is kind of the same momentum. So yeah, copy all those. Sorry to inundate you all, and thank you for your time.
Thanks, Rebecca. That's a lot, but I'm glad we went over that. Those are some great resources. Next up is community outreach with Christian. Hello, Zian. Hello, Christian.
Hi. Can you guys hear me?
Yes.
Great. Nice to see everyone here. I think I'm looking down here at the amount of participants, and we have 126. So it's just from my perspective, that's a lot. And it's really great that you all are here and really engaging with this stuff. It's groundbreaking and crucial work. So I want to talk about community partnership kind of in the context of harm reduction, but also in the context of just general sun work. And this is something that you should ask yourself is, who are your community partners? This can be, it's going to be county by county, variable. And but knowing who your community partners are and what they can do. So are these groups, organization, and people potential partners for harm reduction? And why or why not? So can this community partner be a place that offers naloxone, that offers clean needle exchange? Or are they just some place where you can outreach them and have them refer you? Do they offer housing? Do they offer clean clothes, food? Especially when we're coming into the winter months, a lot of the patients we see are going to need those other kind of supportive, needs that we all take for granted to help support and facilitate the recovery. And then going out there and approaching them about harm reduction and facilitating change within their organization. This doesn't mean you're going to fix them, quote unquote, overnight or make them do anything that they're uncomfortable doing. But it is a way to start a conversation to see what are they willing to do? How can we start to build that relationship between you, the navigator, the hospital to start medication for patients with substance use disorder, and these quote unquote community partners that could, support these patients in the recovery in ways that you in the acute care setting of the emergency department or of inpatient might not be able to do. And that's not to say that you should be discouraged from trying to do the most, but there are some things that you as a son are going to want to do for your patients that you may not have the capacity to do. And using your community partners, I think, is a big, big thing. And it's both you bringing patients into care and offering them treatment, and then the patients that you've seen in care and gotten into treatment, how can you best support their recovery with not just medication and a follow-up appointment and being, respectful and nice to them? How can you do a little bit more? And these things are really, really crucial. And again, when patients, stop using drugs or reduce the amount of drugs they use, and they start making that progress and that journey, these community partners can be real big supports and really help you in those first few steps of their recovery. And the last thing I want to say about this is all of your community partners recognize that if you're getting pushback, if it's difficult at the start, everyone, for the most part, has good intentions. And working with them, having those quote unquote conversations and really, really building those relationships will ultimately actually make their jobs and your jobs easier in the long run. It may be difficult to start, but making everyone's job easier in the long run, and it will ultimately help all of us serve your community, these clients, these patients who deserve this type of care, really help them in their recovery. Again, thank you all for being here, and keep up the good work.
Great. Thank you, Christian. Next up is educating the community. Tommy, how do we do that for harm reduction? How do we educate?
Hello, everybody. I'm Tommy Trevino, UC Davis Medical Center, educating your community. Everything that Christian just said practically was on my mind, but I'll just share with you guys how I do it. My community, whoever I'm going to work with, I invite them over to the hospital. I give them a tour. I show them the patients that I'm working with. I want them to get the feel and know my population that I'm dealing with. That way they get to know where I'm coming from. And also, I like visiting their facility and see what kind of services they have. And if it's something that we can work together with, then we make I'll make an agreement with them. An example would be we start people with 60 milligrams of buprenorphine, 2-week prescription, they're discharged, connect them to the clinic. They know that the patient is going to show up there with the 2 weeks prescription. If they make an appointment a week later, that means they have a week left, right? Things like that. If it's a patient that is struggling for whatever reason or giving somebody a hard time, they'll call me up and we'll discuss that patient and kind of focus in on it to see exactly what is going on and how we can help that patient. We kind of just educate each other on our services and what we have going on. But I build strong relationship with my partners. I have lunch with them once in a while. I have a cup of coffee. We'll meet. If it's someone that I don't feel that is helping my patients, then I won't connect with them. I won't waste my time with them. I just go with my feeling, my heart, my emotions, and if it's somebody that's really going in there to help the patient, I'm working with them. If not, I'm not going to waste my time with them. But a community, like Christian says, know what's out there, educate them on what you have to offer and what your patients need. And that way, you're not wasting the patient's time or your time. Thank you so much.
Thanks, Tommy. That's great to say. You know, I love the fact that invite them for a tour, any community partner. I'm inviting our food bank, pantry, food pantry to our hospital just so that they could see. They work on patients on a different level. So great idea. Invite them. Last up is Latoya Mitchell with the Naloxone Distribution Project. Latoya?
All right, so you guys should know me. I'm Latoya, the Sun Program Coordinator. I'm also a part-time Sun at the Bakersfield Memorial Hospital. But before we get started, I want to know, and yes, it's a little bit cheesy, but that's how I am. Who is down with NDP? So if you have a naloxone distribution program running through your hospital, type NDP in the chat. While you guys are doing that, I'm going to go ahead and continue with my flight information. Love to see that. Yay! So many down with NDP. Okay, so I'm also going to share in the chat in just a minute the guide to naloxone distribution. CA Bridge has really created so many great resources and support systems for guiding everybody through these processes. So if you don't have NDP yet in your hospital, take a look at the guide on how to do it. A couple of things to know for what's new with naloxone distribution. One thing is that the expiration date has been extended. It was 2 years. So if you have something that shows, it's going to expire soon, just rest assured that you have another year added to that. They've extended it from 2 to 3 years. And great to see those who are still working on NDP. Fingers crossed and more power to you to get it soon. The next thing is that there was a recent shortage on naloxone. Even though it was the injectable form, some sites use injectable forms, and some syringe exchange programs use the injectable form of naloxone. So I really do encourage you to order extra. Don't get caught, especially like my site was. We ran out after the overdose awareness campaign. We ran out. So we had to revert back to writing prescriptions for naloxone. And so the doctors were a little bit spoiled with that. But make sure you order enough that's going to last you and have a little bit extra on hand, okay? You can order or opt in to get recurring shipments of naloxone. It would come in 120 units. So that is an option. There are some additional things that you should know about that. Obviously, like you would need to have the higher volume to go through that much. You would need to justify it to DHCS. And then in order to continue the monthly shipments of 120 units, you do have to report overdose reversals monthly, which is a little bit different from what we do regularly for reorders. Now, for reordering naloxone. So those of you who currently have NDP, that is great. I don't know if you've had an opportunity to reorder yet, but reordering is really easy, super, super easy. They actually did away with hospitals having to submit like the terms and conditions with their order. So all you have to do to submit a reorder is scan your logs, which are essentially what you've been writing down, how many reversals have occurred with the kits you've given out. So you scan your logs and email them to naloxone@dhcs.ca.gov along with a new application. And the application is that like 2-pager where the first page you put the doctor's information and then the second page is just your info. You do not have to submit a new standing order if you're still within the first year of your original standing order. So say for instance, if your standing order was signed on December 1st and you're putting in a reorder today with your application, you don't have to submit another standing order because it's still good until December 1st. Let's see. And then again, don't wait till you're almost out. Go ahead and reorder. It's really easy. I'm going to go ahead and drop in the chat the email information that you're going to send your logs and your application to reorder. And so for tracking overdoses, there's a log. When you first apply for naloxone distribution, you agree that you're going to keep a log of, you know, what kits you were giving out. And mostly the most important thing on there is if there's been any reversals. So when you have a patient that you've given a kit to, or any person in the community you've given a kit to, and they come back for another kit, that's where you log what happened with the first kit. Did they use it to reverse an overdose? Did the person live? Things like that. And there are examples of that log with the guide kit that California Bridge offers. And then that's it. If you have any other questions, I'm available as always, and you can reach out to any one of the Sun team mentors as well.
Great. Thank you, LaToya. Yeah, people were wanting to clarify about the overdose reversal. So that's only if you know. Again, that's only if you know. So thank you very much. Next up, well, you guys know this is our last, can you guys hear this? Yes? I'm hoping you hear the graduation theme in the background. We're going to take a poll. We are done with our Sun 101 training. We are so proud of you. You did it. You're fabulous. We want to know how many Sun training 101s did you attend or watch, right? They're recorded. 1 through 3, 4 through 6, 7 through 9, and 10 plus. Well, we're on 10. So please let us know. We're so proud of you. We're so happy that you definitely did this. So congratulations. Take a deep breath. You passed 101. You did it. You're a Sun. You're strong. You're confident. We're really excited for you. We're glad you joined us. These are the total trainings we had. How many did you attend? Most of you have 1 to 3. So need some catching up. We have them all recorded and we're going to put that in the chat. We have 14% that had 10. All right, I'm really happy about that. So that's really exciting. So there's still plenty of time. These sessions 1 through 10 have all been recorded. They're going to be in the chat. We really strongly encourage you, if you have not seen them, to go back and watch them. Everyone has great information about these topics to really help and guide you. So again, thank you for staying with us. we're going to wrap this up for the end of the year. We're going to have a community partner virtual fair. So if you're still trying to engage your community or get some community partners, December 1st at 11 a.m., we're going to have BART, MedMark. We're going to have Tribal Health. We're going to have Bright Heart Health, Pro Wellness, Young People in Recovery, and the National Harm Reduction Coalition. We're going to bring them to you. They're going to come and do infomercials. They'll have time to chat with you. So please look for more information that will be coming email and via Slack, and that's December 1st. So we're really excited. Please fill out the evaluation form to receive CEU credits. Join us on our social media. Thank you so much to our Sun Mentor team. I think you can agree they've done a fabulous job for all of these 10 trainings. And again, thank you to our sons, our substance use navigators, and our counselors out there. You guys are awesome. You guys are working hard. We just had an advisory council, and some of you are just really hitting the pavement. We know that these times are busy, especially with dual diagnosis, mental health. More people are turning towards substance use. And again, thank you for all you do. You have our support. If you're not part of Slack, we strongly encourage you. If you're a substance use navigator with California Bridge, we can put you on our Slack channels for those. If you're a community partner, if you don't know what we're talking about, California Bridge Sun, if you're a community partner or substance use counselor, we have a community partner channel. So type it in the chat if you want to invite. We are happy. Our community is growing, and we're here to support each other. And Slack is the great communication. You can talk to clinicians. You can talk to our Sun mentors. There's lots of answers on there. Again, my name is Sherry Cisneros, and I just want to reach out. Here's our info, as well as Latoya. She is our Sun program coordinator, and with all the Sun mentors, thank you so much. We are going to offer some case studies on Slack, so that's why I tell you, please get on Slack. We're going to be presenting those later today. So if you have any questions, anything in the chat, we're 2 minutes over. I'm going to let you guys go. Thank you so much for attending today.